side. And first topic is epilepsy, and both the presentations are very crisp and simple. And
Bharat दिखाई नहीं दे रहा तेरा वही going to talk to you about epilepsy, and then he's going to talk, the second topic he's going to talk about the suicide. So over to you, Rahul Jain.
Is the screen visible? Good morning everyone. Today we shall be discussing epilepsy, and myself Dr. Rahul Jain, and these lectures are happening under the guidance of Dr. Sharda Jain. So moving on to the topic, coming to epilepsy, first the definition. So yesterday in other video we had discussed seizures. So seizures, just as a revision, seizures were paroxysmal event due to the three terms: abnormal, excessive and hypersynchronous CNS discharges. And when there are two or more than two unprovoked seizures in less than 24 hours, that is epilepsy. So the term unprovoked is very important. That is, there should not be any factor which has been causing the seizure specifically. So if it is a treatable cause, then we won't call it epilepsy. So for such instance, suppose someone underwent seizure due to hypoglycemia. So I won't call it epilepsy. It was just the seizure induced by hypoglycemia. While epilepsy should be an unprovoked seizure and should be two or more in less than 24 hours. Then etiology, most of the times it is the etiology which is non-treatable or causes chronic seizures. So it might be cerebral palsy, post-brain trauma patients will have a scarring in their brain. So that scarring causes all this abnormal hypersynchronous discharges. That's why there are epileptic condition in case of post-brain trauma. Then even genetic conditions like neurofibromatosis and tuberous sclerosis, and conditions like brain tumors and even meningitis and encephalitis can present as unprovoked seizures more than two over the course of 24 hours. Then coming to types. So in epilepsy, actually this is the main thing, that understanding the types and differentiating what type of epilepsy the patient is suffering from. So basic first classification is there is generalized epilepsy and there is focal epilepsy. So generalized epilepsy means the seizure, the foci, the discharges are there in both the cerebral cortex. The whole brain is involved. So even in the picture we can see that the whole brain, both the cortex get involved. While in case of focal seizures, it's only at one foci of the point in the brain where the hypersynchronous discharges are there. Even this generalized and focal seizures are differentiated further along the line. So moving on to the further class, before coming to the further classification, the pathogenesis is same as the same pathogenesis we had studied in case of seizures. That is, excitatory neurotransmitters will increase and inhibitory neurotransmitters will decrease. Basically, the concept is very simple. If I want to have abnormal excessive discharge from one point of the neurons, either they should have extra excitatory neurotransmitter or they should have low inhibitory neurotransmitter. And even my treatment will be targeted on the same thing, that during treatment I want to increase the inhibitory neurotransmitters more in the case where there is abnormal discharges, and I will try to decrease the excitatory neurotransmitter in the treatment. Then coming to generalized seizures. So generalized seizures are the seizures, there are multiple. First of all, in this picture we have discussed the generalized seizures, or the seizures where the discharges are present over the whole of the brain. So under generalized seizure there are further more type of seizures. There is tonic type, clonic type, tonic-clonic type. So yesterday we have discussed generalized tonic-clonic type very well in the discussion, GTCS. Correct. So there's tonic type, tonic-clonic type, clonic type, atonic type, myoclonic type and absence type. So as a general rule, a seizure is called generalized if there is simultaneous activation of entire cerebral cortex and usually the consciousness is lost, but not hard and fast rule. In case of myoclonic seizures, the consciousness might not get lost and the patient might be aware of the seizure. So this is an important point, that consciousness is usually lost, which means whenever a person undergoes seizure, and after that seizure when he wakes up, he won't realize that he has undergone a seizure. So it's usually the bystanders which will point it out that okay, something happened to you or something like that. So coming on to how does these seizures present. So coming to first three types: tonic, clonic, and tonic type. So tonic-clonic type are simple to understand and already have been discussed in a lot of detail yesterday. That is the tonic phase, or if I say only tonic type, they will only suffer from the tonic phase. That is, the whole body muscle tone will become really high, and since the body muscle tone will become really high, the patient will fall backward. On the other hand, when I say the body tone will go low, that is in atonic type. Another type, the person will fall front. So this is how we differentiate between atonic type and tonic type. So just imagine person standing, and then suddenly the person becomes weak. He loses all the body muscle tone. Normally, the usual pattern of falling is front, but when the body muscle tone will become more, the patient will fall backward. So first phase, tonic phase, is patient falls backward. Since all the body muscles are contracting, there is ictal moan, and that's why there is this loud sound. Then there might be apnea associated, and the person can aspirate. So along with vomiting, aspiration can be possible. So we need to turn the patient on left lateral side, and then there can be associated urination and tongue bite. So these are the markers where we can ask history in previous past, that if the patient has suffered this, then we can say that the patient has underwent a seizure. Then clonic phase is rhythmic jerking. So when I talk about tonic phase or tonic type of seizure only, then they only suffer from the tonic phase of the GTCS part. When I say clonic phase or clonic type of seizure, they only suffer from the clonic part of GTCS. But when I say GTCS or tonic-clonic, they suffer from both the phases in the seizure. And when I say atonic type, it's the loss of the muscle tone, which is opposite to the atonic type. So I hope differentiating tonic, clonic, and atonic is very simple and clear. Then myoclonic is just the muscle jerks. One very interesting example of myoclonic jerks I will give is sometimes when we sleep and we are trying to sleep, we feel a jerk kind of jerk in our legs. So that is one example of myoclonus. So that sleep myoclonus is normal, and but this myoclonic jerks will come usually when the person is sitting. They'll start having one movement of their hand, and it will be uncontrolled only. But they will, and in this case, the consciousness is usually not lost. And the last is absence type. We'll discuss this. So coming on to tonic, clonic, and tonic-clonic. So this diagram sums it up all. In the tonic phase, the patient will only tonic type of seizure. The patient will only suffer from tonic phase, and then the seizure will terminate. In clonic seizure, only clonic phase. In tonic-clonic, both the phases. That is tonic followed by clonic. Then coming to atonic type, so the person will be standing, and the moment he suffers atonic, his head will fall front. So head will drop, he will slump or fall forward. So this is the main difference between how to differentiate between tonic type and atonic type. Then coming to myoclonic type, basically jerking of arms, shoulder, or head. So we can just remember this picture, that, or we can remember the example of sleep jerks. When we try to sleep, sometimes we feel jerk in our lower limb. So, but that is normal myoclonus. Then coming to absence type, that is normally happens in children. So in this absence type, what happens is that there are very subtle movements and associated with loss of consciousness also. So subtle movements like lip smacking, and then there is eye blinking, there is frequent stares. So the first sign which is actually usually picked up is in schools, that a teacher will saying that the student is not paying attention. So if a teacher is complaining that student is not paying attention, then we should suspect that there is a possibility of absence seizure, and we should not just ignore it. We can say that history of daydreaming can be present, that suddenly he was suddenly he started looking at wall and he started daydreaming, and then again he started writing. So it was not daydreaming, it was the absence seizure, which was just very brief, even for 10 seconds. So that 10-second seizure activity will cause the time lapse to this child, and he will start suffering in his scholastic performance. So yes, any child we get history of knowing that he is not doing very well in the school, suddenly since few days, and then we should just check for absent seizures, or we should get an EEG done. So then coming to focal seizures. So focal seizures are again, in this diagram we can see focal seizures are the seizures which are there's only at one foci of the brain and not present over the whole lobes. So focal seizures are again of two types, that is simple partial seizures and complex focal seizures. So simple focal seizures are the seizures with there the consciousness is intact, and complex focal seizures are the seizures where the patients lose consciousness. Very simple. Then the symptoms are according to the area involved. Suppose if the area of the brain where the focus is in motor cortex, there's a motor cortex, the motor cortex is in the frontal lobe. If the focal area is that area, then the symptoms which will call are motor symptoms. If the area of foci is in sensory cortex, then my symptoms will be related to the paresthesia or some sensory symptom during that seizure. So this was only about type. Then coming to investigations. Investigation moreover are on the same lines of my seizure, that is CBC, glucose, electrolytes, KFT, LFT, ECG, and lumbar puncture, EEG. EEG is to be done to identify the type of seizure, exact type, and to start the guided therapy. The reason behind is that there is specific therapy for type of the seizure. So coming to treatment, if it is a GTCS, we go for valproate. If it's absent seizure, we go for ethosuximide, valproate. Myoclonic seizure also valproate. Focal seizures also lamotrigine, phenytoin, carbamazepine, levetiracetam. So what I want everyone to understand here is that if we see that in majority of the seizures, the valproate can be given. So valproate is an excellent drug which is and has an action through multiple mechanisms. So most of the epileptic seizures, valproate can be prescribed. Then coming to pregnancy. So yes, just one very important topic I want to discuss here is that if a patient plans to get pregnant and is on anti-epileptics, the safest anti-epileptic which is found in pregnancy is levetiracetam. And though it is a controversial topic, but we can safely say levetiracetam is the safest anti-epileptic. And before the pregnancy itself, the anti-epileptic should be changed gradually, and the patient should be given very high doses of folic acid to avoid neural tube defects risk in case of fetus. Then suppose if a pregnant lady is already on some drug, example valproate, and she directly tells us in the 5th month of pregnancy that she was on valproate, then we should never change the anti-epileptic in between the pregnancy because there is a risk of withdrawal seizure, and that will be even more dangerous.
Okay. So she continues with valproate only?
Yes, but we should get a neuro opinion if we can convert into a monotherapy or something like that, because again valproate, lithium and all those drugs are very teratogenic.
Okay.
So coming to I'll summarize the epileptic part. The other treatments available are, they say that putting a patient ketogenic diet, the ketone bodies will depress the brain, and there are increase in the seizure threshold, and the seizure frequency will decrease. Then vagus nerve stimulation are there.
Normally done in children. If you find epilepsy is not getting controlled, then.
Yes. And then there is hemispherectomy and corpus callosotomy. I've just mentioned them for completion's sake. So this much only about epilepsy, and I've tried to keep it very crisp and simple. And
I think so. Now, here just I wish to tell you about the pregnancy and epilepsy. Whenever a woman wants to become pregnant, our policy is that there should not be any history of fits for 3 years, preferably. And in case if not 3 years, at least 2 years, there should not be any fit. Then she goes to neurologist, asks for a change of medication in case if it is required by the neurologist, and everything is okay. He satisfies himself and then allows her to go ahead with the pregnancy. We already put her on a high dose, that is 5 milligram of folic acid is given instead of 0.5 milligram. And we ask them to come on a frequent visit. Say if a person is coming every monthly, we call these people to come every 2 weeks, and in the last 32 weeks onwards, we ask them to come on a weekly basis. So this is what the plan is of a pregnancy, and normally they sail through it. Again, same is when she comes into labor. Again, we have to get in touch with the neurologist that, this is the way the labor is planned, or, she requires things. So again, we want that the neurologist should be available for any help we require.
Yes, ma'am. So we'll summarize the topic.